support general practice and our patients. Well, coming up pretty much in the next week or so is the submission deadlines for many networks, and including that, what are you going to do with your roles as we move forward past the PCN DES? In this episode, we're going to cover all that information in detail. This is the one you need to watch. So let's tech enhance your primary care and learning. Hello, EGP learners, and welcome to this episode where we're talking about basically the additional roles reimbursement scheme and covering everything you kind of need to know about it as we're now in year 3, I think year 4.
Yep.
I've lost track slightly, but we've got lots of information to cover for you, and including in this is the fact that the submission for a lot of the PCN networks and stuff is actually the end of this month, so in about a week or so. But then there's another submission in October that many networks need to be aware of, because that's your submission for what plans of roles you've got for the final kind of financial years and stuff of the PCN DES. And we're going to go through each of the individual roles, talking about our perspectives on where we're at currently within the PCN DES contract, and then also talking about some innovations as well. You know, the key things that you might want to consider about these different roles and how that may work. Definitely jump in and join with us. We really want to hear from all of you in terms of what you think about this as we go along. We're going to cover the challenges, the opportunities, everything basically, aren't we, Andy?
Yeah, I'm really excited this morning to go through this. Yeah, some important dates coming up for people, so hopefully this will give some people some food for thought as they just complete their submissions. We'll be talking a bit about the process of completing those submissions and what people, I guess, need to do with their PCN to make sure that they are setting the right recruitment and workforce plan for the objectives of their primary care network. Hopefully a lot of that work's already been done because time's short before the 31st of August, which is the deadline for submissions for this year's recruitment. Bit more time for 31st of October, which is the deadline for the final year of the primary care network DES leading into 2024. But let's get started really. The first thing I was going to acknowledge, Gandhi, was that things have got a lot more complicated since the first few years of the primary care network DES, and there's actually a number of other ways to employ people as well. So we need to consider that alongside our additional roles reimbursement scheme submissions. A lot of us will be employing other people directly using core funding or funding from the IIF. There's a bit more flexibility about who you can employ and how you can employ them there. That funding's probably being used for managers, network managers, people like that who are supporting us. There's been some leadership and management funding, recently, which has enabled bringing in a bit more expertise, perhaps from GPs, practice nurses, a bit more practice management time to come in to manage some of the more complex aspects of PCN delivery to make sure you meet your IIF objectives, DES objectives, specific management in areas of care homes and so forth. So that's changed things. And of course, people often have staff that are kind of seconded or come in from other organizations that provide support for primary care networks, and those can be coordinated as well. But today we're talking about the ARRS roles. So where do you want to start, Gandhi?
Well, key thing, as we mentioned, so there is this deadline on the 31st of October for networks to make their submissions for this financial year. So this is the plan that they've got that they need to send to their ICBs, as we're now calling them, because it's no longer CCGs and stuff in terms of what they're planning to fulfill for this financial year. The reason for that is simply because then they have a better idea of how much funding is potentially going to be left over. Because every year there is a situation potentially of areas where there is leftover funding that needs to be used, and there's always this scramble around of trying to maximize the use of it and stuff. But this kind of helps lead into that, as well as there is an ask in the submission of what are you planning potentially for the next couple of years, but the actual deadline for that data is not until the 31st of October. So we did want to highlight that that's a key thing, and one of the reasons we wanted to talk about the different roles themselves is what kind of things are they and stuff. So we're going to show you what the submission form briefly looks like. I know this is not going to be relevant for most of you, but it's important to know where kind of the information comes in. So I'm going to bring it up on my screen. So this is just a screenshot of part of it. First thing you need to do when you get the form, only relevant people, it's typically your PCN clinical directors can fill this in, stick in your PCN ODS code, and then you get sent to a form that looks like this. And this is the pharmacy technician role, which is the first one that comes up. And basically it wants you to say, how many pharmacy techs have you got as of the 31st of March 22, so before this financial year started? How many have you lost in the past financial year? And this is important to remember, that the whole thing about part of the DES is that you're meant to incorporate additionality in your planning. So if you lose somebody, you then not only need to replace them, but you still need to go above that in order to satisfy the additionality clause. And then it's got the first quarter, which we've kind of finished at the point of this submission. It's really annoying that you're doing the submission when you're partway through the year, but that seems to be part and parcel of the PCN ARRS. And then the last 3 quarters, it talks about what you're planning. And it does give you accounting kind of amount at the bottom. So as you can see, the cumulative indicator spend, as it says at the bottom on this form, it's obviously 0% right now. But effectively that builds, and when we did our submission for our network, we pretty much got to 99%, I think it was, for this financial year, which we're not gone over, but we still got a little bit of stuff on stuff and things. Important to know, for some of the roles, you've got extra boxes. So the ACP box will come up for the relevant roles, like the pharmacists, like the paramedics and that kind of stuff. And the last thing which surprised us when we got around to filling the form is that there is an extra section about other roles that aren't the additional roles. So this is your GPs, this is your nurses, this is your AMPs, and it's your PCN clinical director. So it's an opportunity to fill in some of the extra roles, and it probably is a nod to the fact that most networks have expanded beyond the additional roles. So they are looking at workforce. And I guess the question is, why they're looking at this? Well, the whole question is, what happens with the PCN ARRS financing and stuff after next year? Because actually that's the final financial year that the PCN ARRS covers. And there is this plan and there is this commitment from the ICBs, as per the fuller stock take, that this funding will be continued. And I guess one of the key things we want to push across to many of our viewers and those involved in the PCNs and stuff, it looks like that is going to be the last financial year for you to get people on the books, shall we say. And whether you'll be allowed to increase further after that is unknown.
Yeah, I guess we don't know the answer to that, do we?
We don't. No.
But I guess one way to lock in that level of funding for your area, for your neighbourhood, is to recruit people as fully as you can into the roles, just in case they only continue funding for existing roles and don't allow access to the full range of funding that's currently available to bring in additional people. I think there was an issue. Now, I'm dredging my memory, Gandhi, but we had the practice MPIG, minimum practice income guarantee. Yep. And I remember picking that apart because it didn't make sense to me locally, because I think our practice had quite low MPIG uplifts, whereas other practices, say just down the road, had higher ones. And I think there was something about the level of funding leading into some new contracts, around 2004, 2005, that meant there would have been an incentive to bulk up on staff, before that was changed, and they didn't want to kind of defund practices. So that's how some practices kept hold of that funding with the top up from MPIG. So I'm wondering if there might be a similar situation. If anybody is been around long enough to remember MPIG in more detail, let us know if you know a little bit more about that story. So it's going to be interesting.
It is. So we're talking about the different roles. There's a variety of different roles that you can explore, and we've covered this in a lot more detail in one of our previous podcast episodes, which we'll link to at the end of this one and stuff. But effectively just reeling them off. So we've got the pharmacy technicians, we've got the clinical pharmacists, we've got the social link prescribing workers, we've got the health and wellbeing coaches, we've got the care coordinators, the physiotherapists, the paramedics, the podiatrists, occupational therapists, nurse training associates, nursing associates, and ACPs. And have I forgotten anybody, Andy?
I think you've missed dieticians. I think you missed advanced practitioners
and mental health workers as well.
Of course.
And interestingly, this year they included the band for mental health workers, which is not in the submission for the ARRS roles. Interestingly, so that seems to come into the other category. And so important to recognize that there's a breadth of roles that you can explore. That provides a challenge in trying to understand the budgeting, doesn't it, Andy?
It does. So shall we bring up the roles on screen and
let's do it.
Talk through them?
So this is from one of the PCN ARRS contract letters. I've forgotten exactly which one.
This is from the Network DES contract,
there we go,
22 to 23. This is from the big document. I can't quite see on the screen which page it is, but that's the the PCN Bible, I guess. So you can go there for this table. Should we just talk through each in turn, really, and see if there's anything innovative, about employing them, and I guess our impressions of the roles as well in terms of their utility.
Yeah, we could definitely do that. I think important to note that one of the downsides of this document is that it doesn't allow you to do any actual planning, because to be honest, it's just a list and stuff. If you did want to consider planning, there is a far better document to look at from our perspective, which is the Ready Reckoner that is provided by NHS England, which has been pretty decent. Although if you want an alternative one that's a lot more sensible from our perspective at the very least. We are again going to recommend that you have a look at the GP Rota Teams version of the PCN DES calculator, which is what we've currently got on screen for you. So you stick your network name in, and this calculates a variety of different funding opportunities for each individual network, including they've included the IAF in this. So that's pretty awesome from my perspective. But here you go. This is the roles calculator, and you can basically stick in the whole time equivalents that you've got, and then this will calculate your running total. Important to remember that this won't be exact, because you will have members of your team on the spectrum of the banding, and you may even have some people above the spectrum as well, and we'll come to that in a second. But it can help to give you an indicative amount of what your spend is likely to be each financial year, and therefore that may help with planning a lot more effectively than just simply a table of the document and stuff.
Yeah, absolutely, Gandhi, and you acknowledge a good point there, and I guess we'll come to it later, but the kind of budget forecasting around this can get quite complicated, particularly when people are on salaries that are higher than the maximum reimbursed, and you have to factor in sort of management costs or supervision costs. There are other costs to employing and looking after these roles which aren't taken into account in these sorts of ready reckoners, but there are real financial costs that you do need to take into account. So shall we sort of talk through? I know I don't have experience of all of these roles, because I think it's probably a rare PCN that has every single one of these active.
I'd be surprised, let's put it that way.
I'm not even sure the budget would stretch. It probably would to have one of each of them. But clinical pharmacists, I mean, these were some of the first roles that came into being and that were recruited to first. I think it's regarded as quite a versatile role within the primary care network, and it's one of perhaps the most useful in terms of using the ARRS roles to meet the PCN, DES and IAF objectives, because they're able to review patients, able to suggest or often make changes if they are prescribers. So it's a very useful, very versatile role. So I think there's a lot of clinical pharmacists employed in primary care networks out there. Any additional thoughts, Gandhi?
Yeah, so it's probably one of the more established roles out of the list that we've got. You know, there were previous examples of pharmacists working in general practice prior to the DES coming into play, but that's significantly increased since, you know, the DES kicked off, and there's been funding for that. There were the NHS England pilots for some of this prior to the DES kicking out. And as you mentioned, it's one of the roles that seems to hit majority of the DES requirements. So, you know, in particular, we're talking IAF, so the transfer of inhalers, for example, ideally suited for our pharmacist colleagues to look at that. Some of the prescribing elements in terms of the cardiovascular outcomes, you know, management of hypertension in particular. We know that our pharmacist colleagues can be really effective at doing that and supporting patients. And obviously the structured medication reviews. You know, that's a key component and has been from year one of the PCN DES. So there are definitely key elements, and it is pretty clear to see most networks have taken this on. It's one of the larger of the workforces. It's one of the ones where most networks tend to have multiple pharmacists, and aiming to have ideally at least one pharmacist per practice team by the end of the DES contract. I know that's our target that we're working towards. Important to recognise that you have challenges in terms of make sure you've got a team, and that team structure needs to be understanded things. I think there are innovations to look at. You know, one of the ones we're looking at locally is having a learning, disabilities, and mental health focused pharmacist who spends an element working on that more complicated area of prescribing that can really potentially help practices and stuff. But yeah, it's a good quality role in terms of safety. It's one of the ones that goes into the ACP roles, which potentially has some benefit from there as well. There are some challenges with it though, and I think the biggest one is the recurring challenge that we're going to see with some of these, and that's funding.
Funding. So there were a few challenges that were coming to mind. So if we just go with funding, I know initially and throughout the PCN DES, there's been a lot of competition for pharmacists, and the bringing online of the DES, you know, really increased the recruitment opportunities for pharmacists, particularly ones who are prescribers. So a number of primary care networks will be probably paying their pharmacists more than the amount that they can get from the reimbursement scheme, and that's traditionally come from the £1.50. And you know, that probably felt okay at the beginning when there weren't that many other demands on the £1.50, and people were just thinking about how to use that. But as the pharmacist workforce grown and we've found other ways actually to deploy that money effectively, that can be a consideration. And particularly if you're bringing new people into the workforce who have similar levels of skills and experience to those already in the workforce, you're probably going to be needing to pay those people the enhanced, you know, rate as well. And that might limit your ability to recruit into that role effectively, because you've got a limit on the £1.50. Of course, we now have IIF funding, which can be used to supplement that. So there are options, but I think that's something to think about. I know, Gandhi, we're probably going to talk about estates a number of times through this, but maybe we'll just talk about where do we put these pharmacists and the other roles, right now, and get that in the air.
So estates is clearly one of the other challenges. They need a clinical space in order to see patients. Potentially, I mean, some of this can be done remotely, but there is absolutely aspects of the pharmacist workload that's more effective when done in a face-to-face capacity. Obviously, checking blood pressures is a key one. That can be challenging to do unless you're with a patient, unless that patient has the ability and the access and the understanding of checking their blood pressure themselves. But there are other aspects, the ACP element. There's still the opportunity for them to do minor illness and other kind of investigations and actions and stuff. I think important to recognise, though, one of the key challenges I think that we've seen with this is twofold. So you mentioned the financial of the salaries of the clinical pharmacists. They are at the top end of most of the PCN staff. It's the only one that allows you to really go up to band 8A effectively. I think the first contact physios allows you to do that. But the reality is most prescribing pharmacists are actually already at band 8A when they start, potentially, by definition being prescribing pharmacists. So their opportunity to develop and extend has been limited significantly by the PCN ARRS, and that is a real challenge for many networks. The other aspect, obviously, with the cost of living crisis we're seeing with many places, people are looking for absolutely increases in their pay. And when, like you said, you're having to pay for that top up, that increase in pay as well is a question mark. How do you fund that? How do you continue to make that manageable? And lastly, and I think we do need to recognise this has been a challenge. This opportunity has created an additional workforce in general practice, but is absolutely cannibalised the workforce working both in hospital-based pharmacies, because that's where a lot of them come from, and community-based pharmacy in the sense of dispensing pharmacists. And actually, we're seeing that now, because actually a lot of pharmacies are now struggling to maintain their workforce. One of my local pharmacists often tells they don't have a pharmacist actually dispense medications because they just, I'm guessing there's a variety of things. But I do think we need to recognise that one of the challenges that the PCN ARRS has created in a couple of the roles in particular is it has cannibalised workforce from other sectors of the healthcare sector, because we're in a workforce crisis. And we're going to come to this part repeatedly throughout this. There is a workforce crisis. There is not the staff available. People are leaving, but more importantly, they're being taken from place A to place B, and that's having an impact across the system. And I think one of the challenges for the ICBs is going to be readdressing the workforce as ever.
Yeah, I agree. And I was just thinking about the community pharmacy referral scheme, for example. That is the scheme whereby we are being encouraged within the primary care network, sort of DES and IF, to refer patients to community pharmacy for simple ailments. But that requires a community pharmacist to be there. And if they're all working in the primary care network, then it all starts to break down. And I think that was the rationale for selecting a lot of these roles, was that they were felt less at risk of creating workforce anomalies within the health and care system. That's why GPs aren't there. That's where nurses are not there as well, or prescribing nurses. But yeah, so it's interesting. But community pharmacists, it's a very versatile role. It's probably the backbone of many primary care networks. Oh, the other thing, it's going to come up later, but just this issue around supervision as well, and the capacity to supervise.
We'll come back to that one, I think,
Put a pin in that. We'll come back to that later.
Next up on the roles, so we had pharmacy technicians. So this is a potentially support role for the pharmacists in particular, but I think they have their own skills and uses as well. And I've heard really good examples of using pharmacy technicians within IT practices and networks in particular. One of my favourite ones I've heard of, and I consider it an innovation, is the fact that you can use pharmacy technicians in combination with care coordinators to create a prescription requesting service for your local area. And the benefit of that is then you direct patients towards the medication they want and need, but more importantly, you can potentially really drive down cost savings in terms of appropriate use of medication. So, going through it with patients, do you actually need your blue inhaler? Why do you need your blue inhaler again? You just had it a few weeks ago. Actually, is there an element of proactive review that comes into place with this? And also it takes away some of this, and let's be honest, it is a conflict in general practice and pharmacists in particular, in terms of community pharmacists. The fact that some pharmacy chains in particular have a habit of requesting absolutely everything on the repeat medications for their patients, and the wastage that causes, but more importantly, the potential prescribing harm that occurs. I think for other things like pharmacy techs taking on things like DMARD, monitoring for practices and stuff, and even acute requesting of medications in terms of supporting the engagement of patients and stuff. And I think, I've heard of really good examples of pharmacy technicians being used. The challenge, finding them?
It's difficult. We have one in our primary care network. I think they're really useful for making existing pharmacists more effective, actually, and making them more effective with their time, because I think pharmacists have worked with pharmacy technicians for a long time, together in community pharmacy and all pharmacy settings. So they actually, I find they work really well together, and actually the use of our pharmacy technician is managed within the clinical pharmacist team, and they make really good use of her. The other thing that our pharmacy technician has been really good at, because they came from community pharmacy, they know how community pharmacy works, and they've actually been quite good at building relationships with community pharmacists to help us get the community pharmacy referral scheme off the ground, and to address some of the bulk ordering of unnecessary script issues that occur within some community pharmacies. So that was a good experience of their roles. I think that's a good role as well. And actually, because the supervision of that role is handled within the clinical pharmacy team, the impact on the practices in terms of needing time for debrief and supervision and so forth is much lower with that role, which I think can be an attraction.
Absolutely. Well, I think that liaison service is really important, and probably an area we really do need to develop across the board in general practice. Biggest reason from my perspective, I think, is drug shortages is a massive area of conflict and challenge in general practice, both for practice clinicians like ourselves in terms of general practice, in terms of the pharmacists managing it all, and absolutely patients who get stuck in the middle for this kind of thing. And that pharmacy tech role can act as that liaison to prevent, hopefully, some of that kind of stuff. I would love to have a pharmacy tech in our network. We've not been able to find one. We had one briefly for a short period of time, and we've not been able to re-recruit from that. So I think it's a potentially useful role that can have an impact and stuff. I think if we talk about the next one, so social link work, and then we may go to some of the questions and comments. But next up, we've got the other big role that started the PCN ARRS. So that's the social link prescribing workers and stuff, which, I think there are so many opportunities that exist with this. There are a few challenges and a few things to be aware of. I don't know if you want to go first, Andy?
I'll talk about the benefits really first. So, a big problem that we have is that, not all of the patients that we see have a health problem as the primary reason why they've been consulting the GP. We're going to be talking about health inequalities next week, but actually somebody's satisfaction with their health and their life and their health outcomes are dependent on so many other things other than their access to good quality healthcare. That's only about 20%. The rest is all issues around their housing, their employment, their social connectivity and support systems, and actually,
especially post-COVID.
That's amplified some of these health inequalities and some of these issues, and particularly connectivity has been difficult during the COVID period. So actually, and affecting those things have been very difficult for GPs and practice nurses to do in a traditional practice setting, because we don't have time or the ability to address all of these issues. Managing people's health needs is a job in itself, and that's where social link work prescribers and the big hope around them exists, really, that they can help patients deal with some of these other things, take a bit of load off normal general practice who aren't really well suited to deal with these things. So that's kind of the big premise behind social link work, so I suppose social prescribing link workers. And I think they've always been addressing that issue, and they're beginning to get effective at it. Do you want to talk about some more benefits or some of the
so I think there are definitely benefits for the team itself, and I think that's the key thing. I'd say you're going to need a team. Having one social link worker across the whole network is just not going to work, first of all, and this is absolutely one of those roles where a team is essential. I think the understanding they can have in terms of local resources can be really invaluable in helping patients in terms of that aspect of tackling health inequalities. I think the challenge that I think many people often don't realise, don't appreciate, is that this is not a role that's going to have an impact necessarily in the patient journey within that single consultation. This is something that's going to take time to have that benefit across both that individual patient's journey and within the practice population. I think that's one of the real problems with this. It's trusting that it's going to have a benefit for your local area over time. And that's unfortunately not how a lot of the NHS management works. They want impact, they want investment, and even clinicians. Let's be honest, a lot of clinicians, they don't necessarily see the potential benefit this can have with individual patient journeys. I think the other aspect is that there is an opportunity for breadth for this role, and we talked about innovation. One of the ones we've got locally in our areas, we've focused much more on having a financial social prescriber link worker, and that's with a view to specifically helping with the austerity and deprivation aspects that we are seeing in our local area. Both Andy and I work in quite highly deprived areas, high up on the ICD scores and stuff, and things and stuff. That's a driving factor for the way that patients approach us and stuff. So actually, we need to help patients tackle that, otherwise it's going to be a problem. Yeah.
Candy, I was just going to pick up on what you were saying about people's sort of expectations of the role at the beginning, and what I think the role has turned into, and perhaps some of the frustrations that clinicians or some people have with the role. Because I think our clinicians initially sort of saw their role as being a bit similar, that we would count it or quantify it in a similar way to the rest of our clinicians, in terms of you have slots on a rota and you see people. And I think that's what we were doing initially. But actually, I think the role has become much more, and there are things that they're doing now which are a little bit harder to quantify. For example, taking a group of people on a walk around one of the local parks, whilst obviously talking to them and, signposting them to different places. That's a lot harder to quantify, but actually that kind of community work is really, really valuable. The other criticism that has been sort of made about this scheme and this role is they're largely link workers or signposters. They're signposting to services or connecting people with other services. And there's a lot of funding behind social prescribers and signposting, but what about the destinations? What about the places that they are supposed to be referring people to? Is there the funding to take that extra capacity? And I think the answer has been probably not, which is why I've been really encouraged to see roles like the financial wellbeing social prescriber come into place, because that's taking funding for social prescribers, moving that funding to organisations that know about helping people with finances, like a local council, for example. In some areas it might be a housing charity or citizens advice bureau, and actually using that funding to enable that service to provide a specialist who knows what they are doing and how to actually get to the heart of people's problems in these areas of their lives. So actually, using that funding to create the destinations as well, which I think has been an innovation in how the funding's used. People didn't really necessarily think about that at the beginning. So it's another versatile role.
It is. I think there is some dangers in the fact that because of this particular kind of workforce we're creating, there is sometimes the view, and I guess one of my concerns will be with the new world of ICBs, that they take on roles that other parts of the system were potentially doing, and therefore they're not funded anymore. And we have unfortunately seen that locally. I mean, the financial social link worker is actually an example of that. So the local funding was stopped. So therefore we've supported the creation of a service that is basically doing what was being done, but actually recognising the value and challenge that has, particularly in light of the cost of living crisis and that kind of stuff and things. So we felt that was a service that was needed in that respect. But I think this is an area that has the real potential for helping patients, but it is very hard to quantify it, which is unfortunate that it is being quantified in the IAF and, in terms of numbers and everything else. But it is potentially achievable, pending all the other kind of stuff and happening and stuff and things.
You're right though, Gandhi. I mean, at the end of the current PCN DES, if the responsibility for these staff or the funding moves outside of the neighbourhood, I can see them being used for all sorts of things and propping up missing funding in other areas of the services to support people. But moving on.
So just before we crack on with the roles, we are going to go to the comments. We've had a fair few, but before I do that, one thing we haven't mentioned is the fact that this is one of the first times me and Andy have been back in the same room, and we've come to you in a slightly different format as well. We're on a couch, we're talking with each other, we're doing things a little bit differently. So if you like this, give us a like, give us a thumbs up, and if you don't like it, tell us in the comments how we can improve it, because we'd really like to. We're going to be looking at trying to do this a little bit more often now. So definitely let us know what you think. In terms of the comments, well, we've had a few. So Christina mentioned about it's important to remember the return to the 23-24 is indicative only. So that's the future one. It is important, it is indicative, because you're signing up to potential what you could do. And as we're going to comment a few times, workforce challenges in particular may prevent you from doing that. But it doesn't commit you to anything. Absolutely correct, Christine.
Yeah, that's what I was going to ask actually, Gandhi, because I filled in a number of these over the years. And then actually what we've done in practice is often different, because you can't recruit to certain roles. So you place an emphasis on other recruitment, pull recruitment for forward from future years. So is there any indication that this year will be any more binding than previous years?
I don't see how it could, to be honest, because we just know the workforce is so crap, for lack of better terms, that, you know, whilst we're trying to achieve certain things, you know, literally we've got to the point where we've had offered people jobs and they've gone somewhere else, and then you have to restart the recruitment process, and it is so challenging. Or
you have people in an existing role who seem to be doing fine, and they get recruited by another primary care network.
Exactly. And the pinching and poaching is crazy, people out there. You do not understand how much of a challenge this potentially is for networks. Hearing from JC Melody, regular of ours, and a shout out to you, JC. Thank you for joining us again. So Pharmacist has saved at least 6 GP appointments in my household. Their consults are quick, efficient, and very helpful. And also commented a bit later that teamwork makes the dream work. We talked about that team aspect with PCN teams and stuff. It really is an important factor and stuff. Zalan, so he's one of our regular viewers as well. There's been a big shift in the tech training as pharmacists are GS lifting. I'm not quite sure what that meant to say.
G shifting. Don't know what that is.
To all prescribers. The tech role has been expanding, and we're doing more previously done by pharmacists. And definitely agree with that. I think also important to recognise that the pharmacist role is something that can work remotely as well. We've had lots of examples of that. There are, yes, there are definitely some aspects that are far better done face to face. Physical checks and more challenging consultations, like, for example, opiate reductions and benzo reductions and stuff, but definitely a role that can work really effectively and stuff. And then Christina's come back in with, has anybody explored a job share pharmacist, e.g. morning with the community pharmacist and afternoon with the PCN? Interesting. I suspect there probably is somebody out there that's done that.
We have one, I think possibly 2 of our pharmacists are actually part-time. So they're kind of doing that role. I don't think it's quite what Christina was talking about, but they're obviously working part of their hours in a primary care network, and the other part they're working in community pharmacy. Often they're family owner run pharmacies, but they're sort of diversifying what they're doing, which is interesting.
And Christina comments that unfortunately that she's also noticed some of the impact the pharmacist drain has had in terms of the local area, and their pharmacist has been closed at times. And thank you again for the lovely comment. Nice to see you two made up and sharing a sofa. There's never been a rift. Just for clarity on that, it has purely just been ease of use, and obviously COVID has been a huge part of the reason why Andy and I went virtual for a lot of this. But we are looking forward to getting back into the swing of things properly and stuff. But hey ho, let's crack on with the other roles, shall we? So next up is health and wellbeing coaches. Want to talk about it, Andy?
Yeah, I really love this role. So one of my interests, and I've actually moved from the clinical director role into the health inequalities and population health role. And one of my interests has been population health and health inequalities. And one of the problems in our area is that people struggle because of the environment and all sorts of factors to make healthy lifestyle choices. And people struggle with classic lifestyle issues like smoking, obesity, these alcohol, these sorts of things. And the health and wellbeing coaches, we've only got one at the moment. I think we've got another one joining us very, very shortly, and we intend to expand this role because we're finding actually they're really impactful if you get the right people into the role. It's really helpful for those population health issues in that kind of preventative area. And our health and wellbeing coaches doing Pilates classes, taking people on walks. They're doing a combination of kind of individual health coaching and group activities that the social prescribers can refer into. So producing some capacity and some things to do in the area, and making lots of connections with local sports centres and so forth. She's also decided that the area we work is, this may not statistically be true, but she's decided it's the mobility scooter capital of Europe, is what she says, because she sees too many young people on mobility scooters. Many of them will be using those devices for good reasons, but she thinks that there is a problem there about people giving up on mobility too early. So she's really focusing on that. And she's even been to some local businesses and done clinics of the workers who work in these local businesses, so, packing factories, warehouses, things like that. And I had quite a good response from the people that work there, actually talking to them about about how they look after their health, and it's actually helped us understand a little bit about the local population. So, for example, a lot of people don't understand that there are calories in alcohol. That when you have your gin and tonic, actually there's calories in the gin, or in the beer that people drink, for example. That's just one of many things. So yeah, I'm really quite enthusiastic about this role, and it's a good opportunity to get people from the local area or nearby coming in, perhaps people with personal training backgrounds, or other backgrounds. Often it's people who did work for the community sports and leisure departments where there's no funding for their projects, that are moving into these roles. So there's a little bit of cannibalism there, but very enthusiastic about this role. Actually, you had much experience with health and wellbeing coaches?
So we had two. We're going down to one temporarily because we're looking to recruiting a replacement for that. I think the role is really, it fits with the social link workers, in my view. It is, again, it's one of those roles that you're not going to see a direct impact from that single consultation. You're going to see the impact moving forward. And it is that group aspect of things. And that's one area I would really push to look at. Group consultations facilitated by health and wellbeing coaches. And I think it's a role that can really enhance the use of some of the other aspects. So, having a physiotherapist and a health and wellbeing coach doing a group consultation about mobility, that could be delivered by video, that could be delivered face to face. Actually that's real power there. That's real opportunity. Similarly, if you're looking at medication concordance, having the health and wellbeing coaches talking about how implications of use of the medications with the pharmacist there in a group consultation can have real impact. You talked about mobility from the scooter perspective. I think there's real opportunities. But actually the biggest one for me is, and again, it is a constant worry for me, it's the cost of living crisis. It's the fact that in several areas of high deprivation, we're going to see people having to make really bad choices about what they're having to do for their livelihoods and for their diet and for their activity, because they just do not have the financial resources to have a healthy diet. And actually, we need to consider how is that going to impact their health longer term. So, where can you get cheap sources of protein from? Where can you get cheap fruit and veg from? Where can you get, effective use of, dietary support and things when you are having to literally live day by day and stuff? And actually, I think that's one area I'm hoping to expand our health and wellbeing coaches to look at to support our patients, because actually when that falls down, the rest of the health falls. Your engine is only as good as the fuel you stick into it, and if you end up having to put bad fuel in, then your health is going to deteriorate. And I think that's a massive part that where this particular role can really benefit our populations in particular.
Yeah, I want to link in one of the later ones actually, because we'll acknowledge dietitians in a few minutes. And that's not a role that I've had direct experience with in primary care networks. I don't know if many are using dietitians locally, but I often think the sort of input that we need for those kind of population health issues within the area are actually fairly sort of simple and basic. And I've often wondered whether you need dietitians for that. Perhaps you could do with dietitians coordinating, the approach that other ARRS roles are kind of using and deploying, just to make sure that it's sensible. But maybe that's something that is a bit more sort of city or not neighborhood but place level, because the actual dietitian skill set feels like it might almost be a bit too specialist for those things. I don't know if you had any thoughts on that and the dietitians. I know we're jumping around, Gandhi, but
okay, so let's jump to the dietitian, shall we? So I think we've covered the health and wellbeing coaches fully. Dietitians, I think, again, it's not an area we've particularly looked at because we've struggled to understand how we can utilize that more effectively. However, like you mentioned, combining that with the health and wellbeing coaches to support our patients with making healthy food choices, absolutely. Supporting them with the other roles, patients, for example, we're seeing an increased number of patients with gluten sensitivity and stuff. How does that impact their health and picking up celiac disease a lot earlier? There are other challenges. So, for example, newborn babies with reflux and cow's milk protein intolerance and stuff. And actually, can there be a created service within your network that helps to manage that health anxious parents who are worried about their health of their child, and actually recognizing what is true cow's milk protein intolerance versus what is potentially just colic and stuff? Is there potential extrapolations that can be made from there to help with things? But the big one obviously for dietitians is going to be obesity. Let's be honest. We have seen a massive reduction in localized healthy weight services and that kind of stuff, and they've recognized the error of their ways. But actually, we need to tackle obesity across the populations, no matter where you work. It's a problem that's everywhere, and it's a problem that has a huge impact on the health service. It's a problem that has a huge impact on patient health. And one of the other things we're realizing, obesity is not just energy in and energy out. It is so much more complex than that. And growingly with the data that's coming out and the evidence that's coming out that obesity is not just about calorie intake. It is a proportion of it, absolutely, but it is not just about the calories themselves. It is about the types of food. It's about other aspects. It's our relationship with food, that kind of stuff, and that's where a dietitian, I think, can have real impact.
Yeah, I agree. You just, again, we may be jumping around a little bit around some of the considerations here, Gandhi, but you just made me think about the provision that some of these ARRS roles can end up providing services which are also commissioned elsewhere. I was just sort of thinking about cow's milk protein allergy service, and so forth. And that was something that we were really kind of worried about and occupied a lot of our thought processes at the beginning of the primary care network, DES, that we didn't want to duplicate services that were separately commissioned elsewhere, and that didn't feel right. COVID came along, our attention's been elsewhere. I get the sense that we're potentially less worried about that now. I don't know if you've sensed a shift
maybe
in that.
I think it varies across different areas. I think there's still an element of concern that, as ever, health is going to be defunded to provide for other areas. And I think there is that absolute concern as we move towards ICBs, primary care in particular being defunded to provide other services because, our contract allows that in some way because it's capitation based and stuff. And then this is something we'll probably talk about again in our health inequalities session that's going to be coming out next week. So definitely join us for that. But I think it's important to recognise that it's a concern.
Different areas are going to go with different solutions. I guess some primary care networks, they'll be more focused on this, and other primary care networks will be much more relaxed about this. And I guess that's the beauty of having local solutions, I guess.
So aware time's ticking on. We probably need to get moving through some of these roles. And the last kind of non-clinical-ish one is the care coordinator one. I think this is a really opportunity role, basically. So let's have a quick look at the document so you can see the funding and stuff and the opportunity. So care coordinator is generally banned for in terms of agenda for change and stuff. Lower end of the pay scales, and this potentially provides opportunity to have more in terms of numbers. What's your thoughts on the care coordinator, Andy?
I think it's a really versatile role, actually. Later on in the PCN DES document that we've been showing on screen, there's the description for each of the roles, because what you need, what you deploy them to do has to map back to those descriptions. But there's actually quite a lot of flexibility in the care coordination role. I think they could be used for a lot of objectives and issues within IIF and within the primary care network DES, such as issues around helping people find their way back to cancer screening. There's always a patient contact sort of navigation or coordination of information element that's needed for these roles, but it is actually so versatile. So some people are using these roles to help with cancer screening, attending cancer appointments, making sure people attend 2-week waits and so forth, because there's a patient contact and coordination of care element to that. I know you'll probably talk about safeguarding care coordinators in a minute. I think that's something you've done in your area, which I think is really good. Coordination of information and care around care homes and home round lists, and supporting patients be more effective and making sure that information is there when the clinicians go to do their home rounds in care homes remotely or non-remotely, helping with childhood vaccination coordination and groups that people are having difficulty reaching for vaccinations. So it's a really, really versatile role. And you're right, I think the level of funding is low. That it's a shame that these people, there isn't more money there for these people, but actually for that kind of coordination role, that level of funding allows you to have quite a number of these if that's the direction that you want to go. You've got to use your imagination a bit more with this one to do something useful with it. It's not like a pharmacist that it does what it says on the tin, but really, really useful. Yeah. Any thoughts?
Yeah, so I absolutely, it's probably the most versatile and broadest out of the different roles in terms of what they could do. And like you say, using the imagination can really help. We explored having a safeguarding coordinator from year one, effectively, as soon as the funding was allowed to work. And it took about a year or so to get it approved. And I think it's a role that potentially is going to have real impact, because we have, in particular on our network, we have one of the highest safeguarding caseloads across the whole city. My practice actually has more than all the other practices combined. So, that's a significant amount and stuff, and helping those patients, but more importantly helping that workload is really paramount. I think there's various other opportunities. So we've got quite a breadth of care coordinators in our network. We've got a safeguarding care coordinator, we've got a cancer care coordinator, and we are almost on the point of having a digital care coordinator, so someone helping patients with online access and using the digital opportunities and stuff and maximizing that, because we've seen obviously challenges some cohorts and particularly deprived populations can have with that aspect of things, and I think there's various other opportunities. However, I'm going to be clear. I think general practice has massively missed a trick with this, hugely so. I'm going to give a shout out to one of my Twitter colleagues, Parody RCGP. Okay, because they came up with this clear insight that actually, in retrospect, I think if all networks had been aware of this from the start, we probably would have seen a completely different situation in general practice. And that's rebadging the care coordinator role as a GP assistant. Because actually, what is the role? It's navigation of patients to find the correct source of care for them. And actually, one of the real workload challenges in general practice is the fact that there's a massive mismatch between service and delivery across the whole healthcare system that general practice has had to take on, because everybody else has kind of said, well, we're dumping it on you. But actually, a care coordinator based within the practices could do that. Now, a lot of practices are probably thinking, well, that's kind of what our reception teams do. This is a way you could have funded your reception teams. Let's be honest.
Cheeky.
Well, no, I'm not going to, it's not cheeky. Okay, let's be clear. The PCN DES has in some ways been really effective and stuff. And in other ways, it has absolutely screwed up general practice. And this is one of the ways it could have rectified things. And actually, if this had been available and thought of probably earlier on at the time, I think many more networks would have invested time in terms of creating care coordinators for our patients, which is effectively what our reception teams do, having it funded to support practices, but looking at aspects of referral management, results explanations, organizing care within those more challenged populations to make sure they attend their appointments and things. How is that not the care coordinator's role? Yeah,
it also sounds very much like a lot of what the receptionists do. So I fully appreciate the overlap. The overlap here. Yeah, absolutely.
I know there are some areas that have looked at doing this and looked at supporting this. There are more challenging aspects in terms of our high use patients, having them have specified care coordinators to help them in their patient journeys, because actually they're the ones that have significant use of the healthcare system and prove challenge on and strain on the services. So we're not meeting that need. So how can we do that? Use a care coordinator to help support them to navigate towards those career places and stuff. I think it's a trick we've all missed, myself included. And whether that's something that networks should consider for the final year to really invest in, because actually, it might work
to bulk up a little bit before the funding sort of pathway is maybe changed.
Why not? Why not? And if there's somebody out there in NHS England who's now watching this thinking, Gandhi, I'm going to come and grab you and tell you off all of this, feel free to do so.
That's an interesting one. So shall we go through? So the remaining roles are fairly self-explanatory. Physicians associates, we could spend time on that. I'm aware we've been talking for a while actually, because this is really fertile discussion ground. But maybe if we move through these with a little bit more pace and then talk about some of the considerations, I guess, in terms of completing these workforce plans. So physicians associates. So we haven't had any in our primary care. You've had a number of them. So
physician associates, in my view, are the most clinically broad out of all the different roles. They can pretty much do anything. And I know there's definitely some antibodies across the whole system about physician associates. And I think a lot of it is incorrectly focused, to be honest. There is a limitation in terms of what they can do. So they can't prescribe currently, that they're not able to do so. And I think a well-trained physician associate can have real impact on a practice. And I say that absolutely hand on heart. We've had a physician associate part of our practice for over 3 years now. The practice runs amazingly because of her and stuff. And we've had an additional one start within our practice in the past few months. Again, really exploring the use of that. Definitely more junior, but actually learning the ropes really well and helping the practice in terms of particularly dealing with acute demand. Across the network, we originally created them with a view to helping manage some of the care home workload. And I think it's really helped in some aspects of that. But it is recognizing that they have limitations. They're not GPs, and as long as that's understood, actually it's a really powerful role that could, again, be adapted in various different ways. They could do minor illness and injury clinics within your practice. They can do care home ward rounds. They can do potentially enhance acute home visiting service in terms of supporting practices. And they can specialize into most other areas to help tackle local focused demand needs and stuff. And One of the things I think we may actually see is the utilisation of physician associates, particularly to help with these acute care hubs that the Fuller Stocktake report identifies, because actually it's one of the only roles that can do that from this, aside from the ACP role. And the ACP role is massively less numbers of people. Challenge, okay, number of physician associates is not great. There's not many of them. Majority of them are more towards the junior end because they're being churned out by some of the local schools and stuff, or they're having to come from abroad. So then they're either, less inexperienced or cost a huge amount of money and potentially more than the banding that allows and stuff. So there's not the middle group yet. That middle group will take about another 2-3 years to come through. So there is those challenges, and I think there's absolutely one of the key challenges I think for most physician associates is making sure they're getting the appropriate level of supervision and support, because that needs to happen.
Yeah, Gandhi, I was going to say we had 2 reservations. The 2 reasons that we probably didn't go for it yet were worried about the level of supervision required and whether our GP practice had the capacity to do that. We also were worried that partly because of that, it didn't necessarily lend itself very well to working across a network. We started out with 8 practices, for example, and there's always a call for equity of access to each of the ARRS roles, which in some ways is, it's fair. In other ways, it presents challenges for making those roles sustainable, fulfilling, and actually workable for the people working them. And we felt that because of the high level of supervision required and that kind of pull to work across at least a few practices, that it was going to be really difficult to deploy that role. Did you manage to overcome those? I
think the realization of when you're looking at supervision, when you're looking at that aspect of equity, it's not going to work in that way. You just have to accept the fact that you're probably going to have one physician associate working in 1 or 2 practices, and then you're probably going to have to explore having more to then work across others. I think if that's the view that you're taking with particularly the clinical based roles, you're going to find that those people will not stay in the network because they're going to be really dissatisfied with the way they work. The only way it may have worked is if you did for that acute visiting service across the whole network side of things. That's the only way I would understand that would work. If not, we have seen time and time, particularly over the time with this, that people do not want to work in multiple practices on a regular basis. 1 or 2, fine. Maybe up to 4 at the most, I would say, because otherwise it gets really complicated. And if you don't think that's true, I would ask any of our GPs, how many of you would regularly want to work in 4 different places throughout the whole week? Locums is slightly different because locums, you have the choice of where you go in and how much you do. But if you are on a regular basis working in 4 different sites throughout the week, having to work with 4 different systems, how happy would you be doing that? Honestly. And if you would say that you're fine, you're better than I am.
It's a recipe for a really stressful job.
It is, absolutely.
So picking up speed, physicians, first contact physiotherapists. So we've got a number of those in our network. It's actually a really effective role. So first contact physiotherapy was a concept that's been around for a number of years before, previously trialled in Nottingham City and worked really well. And there's a framework developed by their kind of, I don't think they have a Royal College of Physiotherapists, they might do, but they have a well-established national body that developed this concept and all of the supporting tools and documentation around FCPs, first contact physios. So that was something that can be and has been deployed almost kind of off the peg, fresh out the box, to primary care networks. And I think they say a quarter or a very high proportion of GP consultations are musculoskeletal consultations. And this allows them to be sort of easily sifted off and streamlined by your care coordinator receptionists to see them instead of GPs. So it has a real noticeable impact on general practice capacity. So it's been really, really popular with practices. I guess one of the downsides is that it doesn't necessarily lend itself really to many of the IIF targets or PCN DES requirements. So in terms of actually meeting the objectives of the primary care networks, it's potentially one of the less useful ones, interestingly, despite having a very high impact on workload. So there's always a bit of a tension there. But I've had very good experience first contact physios.
Agreed. And I think it's also one of those roles that as time develops, we're actually going to see even more its usefulness. So in particular, there's 2 aspects that have limited some of the FCP usage. So number 1 is the ability to request radiological investigations directly. And that's down to the I-refer criteria and stuff. And some of that is changing. So we are seeing that hopefully soon physiotherapists will be able to directly request certain investigations like x-rays and that kind of stuff. The other one is the fit notes.
Okay.
So as of last month, physiotherapists can actually give a fit note. Now, yes, there's the training that needs to happen to deliver that, but actually that was an element of workload that revolved around musculoskeletal consultations that end up having to go back to the practice team, specifically the GP supervising them, because that is no longer a factor once the training has been done. Actually, I think that's going to have a real benefit and even enhance this role further forward. So yeah, it's not going to happen straight away. It's going to take a few months for everybody to train up and to feel confident and capable of doing it. But once it's done, and my personal experience in the network, many people were anxious about using it. They thought, I'm not quite sure. It is the one role everyone keeps asking me to find more of.
Yeah.
People want more.
Yeah.
So thank you to our physio colleagues. Absolutely, this is a key one. The developmental criteria is a bit more challenging, and it is one of the roles that is eligible for the ACP criteria as well. So there is that tension, I think, that's going to come around about funding with this particular one. And far superior, this is one that needs a clinical room. So estates is a challenge for some of this because it needs. We've tried video-based FCPs. It doesn't work anywhere near as effectively as face-to-face. You need to have them face-to-face based.
Yeah, agreed. But yeah, I really like that role, and it feels like it should be a natural part of general practice, doesn't it? To have physios, in addition to pharmacists, and other roles. Dietitians. I think we talked about dietitians.
I think we've got
already.
Yeah, podiatrists.
Again, not something I've got direct experience with. It feels like something which is commissioned separately, although often not commissioned in a way that is as accessible for patients as patients would like. And the criteria of people who are able to be funded to see a podiatrist over the years has really
Andy's being very kind, and I'm deliberately not going to comment on this, otherwise I probably will get myself in trouble. But for lack of better terms, I'm just going to say our local access to podiatry is crap. It's commissioned awfully, it's restrictive. So in some ways it's kind of designed to make us want to have a podiatrist, to be honest.
Yeah.
Because actually our local access is so awfully commissioned.
Yeah, I'd be interested to know actually in the comments if other people have gone with podiatrists. It's one of those that feels a little bit niche, but actually there is a big need in the population for it, particularly if services that are commissioned elsewhere are not sufficient to meet that need, but they probably should be sufficient to meet that need. So it's an interesting one. I don't feel I can speak to it with any real experience, but maybe there are PCNs out there where this is a really big priority and they've gone for it.
Well, I've seen some interesting innovations. So I've seen some aspects of using podiatrists to do, for example, AF checks because they're checking the pulses, and that can help with some of the cardiovascular screening aspects of, the PCN ARRS. And actually, if people can walk properly, that may therefore mean that they have less issues in terms of complications like amputations for diabetics, like musculoskeletal problems with some of our more challenged patients. The mobility aspect again feeds into some of this. I think foot care is a really important part of general health, and actually, if that's done effectively, even something as simple as an ingrown toenail can lead to quality of life impact in terms of working abilities. School kids going to school, it has an impact. Not being able to walk properly is a huge thing because of poor foot care. So
what you say is true, but I feel we're stretching it a little bit.
It's so low down on the priorities of the system. I feel that actually that's one of the reasons why it's not often.
And it feels like the sort of service that doesn't necessarily need to be as neighborhood based and tailored as some of the others. You can just, it feels like actually an adequate place level service would do the job. Anyway,
however, I'm going to go to Christina, who's made some excellent comments in the meantime, but these are the two I'm going to pick up. Our podiatrist can give joint injections.
Oh wow.
Okay. And also helps with Dopplers and leg ulcers, which is a massive drain on practice services potentially.
Sorry, Christina, maybe I've got this wrong.
Yeah. So Christina, thank you. Our issue, so I would love to have a podiatrist in our network. We've tried to have funding for it multiple times. In fact, we've got the funding.
The funding's there, Gandhi.
Well, we've got
the funding. For it.
We've got workforce does not exist. That's been the problem we've had. We've had multiple adverts out for podiatrists and we've never had a single one filled. So if you're a podiatrist working in Nottingham that wants a job, do contact us. We'll be more than happy to entertain exploring that for you.
So occupational therapists. So I know in our community of primary care networks, we've got 8 primary care networks in Nottingham City. We work quite closely together and meet and talk often. I know occupational therapists was something that the primary care network based around university practices went for. Can you remember any of them? additional details around that? They had a very specific sort of use case for them, and they were very interested very early to go for occupational therapists.
So I know we were looking at using them in combination with the mental health workers because of the limitation that we had in the mental health teams aspects of things. So using them to support patients' activation and engagement in terms of access, use, ability, it can enhance a lot of the other aspects and things. I think there are some really good use cases of occupational therapists, and unfortunately I've forgotten them all. But I do remember our colleague Ben Gowland, who has done some amazing podcasts on various depths of these different roles. But he did one particularly on occupational therapists, and I remember it being really useful and thinking, I wish I could use some of this kind of stuff in our network. I won't deny that we opted for some of the other roles as a priority compared to occupational therapists, and partly because of trying to sell it to some of our practice teams probably wasn't going to go as well. If it had been approved to belong the mental health one, I think it would have worked really amazingly. Unfortunately, it wasn't. And we couldn't, so therefore that's why we don't have some in our network area. But I think, you know, it's one of those things that can be quite potentially useful. And I've forgotten all the really useful cases of it. And so I'm really sorry, so I'm going to direct you all to the General Practice podcast, Ben Gallen's episode, and we'll put that link down.
There are great interviews with people who do each of these roles.
Absolutely.
So these are really great resource to go and look at. Nurse training associates. So one of our practices has taken this up. Do you have anything detailed to say about this? It's one of the newer roles
so
this year.
I'm probably going to get shouted at by people online for this, but to be honest, the nurse associates and the nurse training associates was basically a way, from my perspective, of badging healthcare work assistants into the PCN ARRS, and massively to help with the vaccination challenge that we had last year in particular. So I suspect that's why it was included. It was to enable people to try and get as many people in the funding to allow to support the vaccination aims in some way, shape or form. I think it could have real benefit in certain aspects, and particularly in terms of supporting practices with some of that lower clinical usage in terms of, you know, phlebotomy, ECGs, you know, aspects along those kind of blood pressure checks and that kind of stuff that, you know, that can be really done well. But it's a nurse associate, so it's basically another way of saying a nurse that's not a nurse, so somebody who's not been able to train as a nurse for whatever reason that may be, and it's a training version of that to allow for that, and it's basically to create a potentially cheaper workforce. And I apologize if I've offended anybody by saying that, but that's my understanding of how it could be used. I think there are definitely going to be areas where these individuals are working amazingly well for their network areas and stuff. And I have heard of some examples. Again, Ben Gowan's covered a couple of those on his podcast and stuff. But I also think that it's a slight fudge.
Yeah, it's interesting, isn't it? And it's going to raise all sorts of equity issues across primary care networks. Equity, is that the right word? Fairness. Let's use that word. Because, you know, some practices will have a larger contingent of healthcare assistants doing these sorts of things like ECGs and blood tests, and other practices may not. And it's, you know, how would that resource be distributed across the network? These are not core contractual things that you need to do as part of your GMS PMS contract. So let's be clear about that. Nonetheless, a lot of practices end up doing them. It's just about how you distribute that resource across primary care networks. I can see that being an issue. Shall we move on to community paramedics?
Yeah, so this is one of the more interesting ones. I think paramedics were always viewed as one of those roles that could have real potential benefit, but there was absolute anxiety around the use of them through the DARS, and the main one being the cannibalization of the workforce. We know that, you know, the ambulance services are massively under strain and have been for the past few years. You know, significant amounts of underfunding, not enough workforce and stuff. And then actually, if you start taking them across into networks, that enhances the problem, because actually they no longer have to do nights, they no longer have to do weekends.
It almost feels like if they were doing the DES now, they might not include them, because they might consider them in the same position as nurses and GPs, and not wanting to pull them out of other services just because of the current stress. But there's a lot of hope around these, and I'm sure they're doing, for those people who managed to recruit them, I'm sure they're doing really good work in other PCNs around the country. I don't have direct experience. We were very excited about potentially using them for a home visiting service, for example, or helping go into care homes, because we felt that they might have some of the necessary skills to assess acute emergencies. I'm not sure how those things would have panned out, but again, it's quite a versatile general role that I think has a lot of promise going forwards.
Absolutely agree. And again, it's just been availability of the workforce that I think has massively limited some of the aspects. And in a way, I think there's also been the governance structure. So we talked about how networks have used other organisations to support the hiring of them. We obviously approached our local ambulance service provider with a view to enhancing the training and to making this a really attractive role. And actually, some of the service level charges that were commented were just made it unmanageable. And a slight part of me kind of suspects that was intentional to basically make it so that people didn't want to do this. But hey, that's my personal view.
Yeah, I think up in north, in some of the primary care networks north of the city, they've got these roles up and running. So it might be interesting to know how those are going. But I don't talk regularly with the people in those areas, not because we don't like each other, but because I just don't have the connections. Advanced practitioners, you talk to us about this role, Gandhi, because I think this is potentially
the advanced
very
practitioners
versatile.
is kind of like a next level up, and this I think was seen as kind of like that team coordination role, but in terms of partly in terms of leadership, but also enabling some more direct level of activity within networks and practices in terms of acute management and that kind of stuff. It is funded at the AA level, which is okay, but again, as we just identified with the pharmacists, actually, it's touching above that in some areas and stuff. And actually, if you look across the NHS in terms of hospital-based care, it's normally 8B, C that you tend to see these kind of more leadership roles being funded at. So actually, it's already outside of the funding and stuff. I think certain areas potentially have used these. There has been a limitation on ACPs, which is also an additional factor. So the fact that you can only have one per network up to 100,000 patient population, over 100,000 population, you can go up to 2 ACPs. Across a network of 100,000 patients, that's nothing, to be honest. So it kind of seems like it's almost a token element of trying to enable some level of supervision, leadership funding to enable within the system. But hey, that's what it is. And then lastly, we've got the mental health workers, which is now
Adult and young people.
Adult and young people now. And there's a variety of bandings. And although it's included in the funding this financial year, as I mentioned earlier, in the submission, the band 4 is not actually included in the submission. I don't know if that's an oversight. If it is, sorry, I've already filled mine in. Yeah. Tough. But it is something that is important to recognise that there is now a breadth of potential funding opportunities for this role. However, the biggest problem with this is workforce availability.
So for recruitment, and people will notice that the figures on the screen, that looks low for an AA role, and that's because the funding is shared between mental health trusts, who are encouraged to be the main employer, and primary care networks, and the funding will be 50-50 across both of those organisations. They will be deployed together, really.
Can be.
So
they changed the words this time round. Remember? Did you not remember this in the days?
I can't quite remember.
So they did change the wording. So last year it was should be or has to be, and I think no. So last year was a must, and this year it's a should. That was it.
Okay.
So should is a slightly softer word, which potentially means that you can look elsewhere for the recruitment of these mental health workers, potentially in terms of the voluntary sector as well. Which is where I think a lot of people are now actually looking for the band 4, and we are as well in terms of the band 4 workers and stuff. But it's again,
different. It's a big role. I mean, we've done lots of work with our communities, and the big priority that comes up is mental health services.
Absolutely.
Mental health. That's the thing that people feel is a real area of focus where I work, and this is a role that can directly help with that. So there was a lot of interest in doing this. We could only recruit 1 last year, 2 this year. We did manage to recruit 1, but they moved away into a different role that was more in line with the type of work they were doing before they took the role with us. So it's been difficult to recruit back into that role. I think there's just so much competition for them. And let's face it, a lot of mental health services themselves are really struggling for CPN level mental health nurses. There's a lot of competition for these roles, but a lot of potential. I don't know if there's much more to say on this role.
No, I think we've covered most of it. I think what probably is worth now talking about is some of the additional stuff that we've kind of alluded to throughout some of this, and we're going to have to do this fairly quickly, aren't we, Andy?
Let's go quick fire. Let's take one each.
Okay,
and we'll allow each other a little bit of one response to it. So I'll go first. So considerations when completing your workforce plan. So is it okay? So I would say, first of all, just make sure you're working in alignment with your primary care network Vision. Okay. Hopefully you've decided what you want to achieve. You'll need to achieve things to do with the DES objectives.
Yeah.
Practices may have identified their own needs as well. Your locality might be pushing you in certain directions of needs. So just make sure you've got an idea of what you want to achieve so that you can recruit towards that goal. And make sure that everyone is involved and that everybody agrees with what you're doing. So that's the place to start.
I've heard of some networks where simply all they've done is got pharmacists and social link workers, and that is it. That's all they've just literally maxed out on that, and not really bothered with any of the other roles, because those are the two roles that massively tick off the IAF in particular. There are other networks where they've tried to do a little bit here, a little bit there, that kind of stuff, and actually may not be working as effectively.
I know we'd sort of reached the conclusion that actually we wanted to double down on roles that we already had, because the effort and requirements of setting up a new role or a new service are quite big. Place a lot of strain on the primary care network management and leadership team, and on practices who need to supervise them to have another different role that's existing. So doubling down on what's already working is one principle people could follow, or expanding is the other principle. If people have capacity to do that and want to experiment and innovate in new areas.
Absolutely. Andy mentioned supervision. Absolute consideration that needs to be put in place. So all these roles need supervising. One of the things that often is touted about in the media is the fact there's no GPs available. Let's be honest, one of the reasons for this is because we're all supervising all the other additional roles. Debrief. I have a debrief afternoon in my practice on Tuesday. Literally, most of my time is spent debriefing other clinicians because of the breadth of roles that we now have within practice, and that takes away my availability. But that's the reality of general practice now. So, but that's a reality a lot of people aren't still quite comfortable with, and also it's a reality that is not, in my view, really accepted from NHS England. They've kind of created this beast and not recognise the fact that this was part of it. There's no funding to support the supervision.
There's no workforce,
and there's no workforce
to support the actual
supervision. So let's be honest. The fact that almost every single one of these roles was indicated had to be supervised by a GP. Yeah, a bit of a screw up, to be honest.
Yeah, but I guess what you're alluding to is there are additional requirements or things that are needed to employ these people over and above the funding that you can draw down from the ARRS,
Absolutely.
The additional roles reimbursement scheme. We've talked about the need to supervise them. Another big one is estates. Maybe talk about that in a second. But there's also, this funding envelope may not be sufficient. People may be having their wages supplemented from other funding areas, so that you were able to recruit, say, that prescribing pharmacist or someone who needed something above the 8A or whatever the boundary is in their particular role. And
management on costs,
That's
IT equipment,
yeah,
relocation costs in some situations,
and the management cost, the cost of managing these people, because they need an appraisal, they have human resource requirements, induction requirements. None of that is covered, and I believe there was initially some thought that you could use like a proportion of the ARRS reimbursement, pay them less than you were pulling down and use the rest for management, which actually would have been quite a handy way of funding management, which is required, but that's not allowed. No. So you can't do that. So you've got to fund that from elsewhere.
The only exception for that was the social link workers, where there was a recognition that they needed some additional funding. I think it was £1,000 per role that was allocated. But all the other roles, again, that's an extra pot of funding. But all the other roles, you cannot take the management costs from the ARRS reimbursement side. And if you are doing that, yeah. So when you're doing, it's not just about doing your workforce plan, but this needs to be done alongside the rest of the planning of your budget and of your estates and room utilization. And are practices willing to provide that supervision and funding, and what does that mean? So there's sort of a bigger planning exercise really around whether you have the capacity to actually employ these roles. But it's new funding, this is positive. Let's be positive about it. The thing that we put a pin in for later was estates. We've talked about it at length. There isn't any funding for estates or new rooms or space to put what are actually huge numbers of new people. You can do some working from home, you can do some working from telephones or call rooms where you have multiple people using telephones all at once, like the receptionists do, which is not ideal for concentrating on complicated clinical
processes and activities. Anything else we need to say about estates now, Gandhi?
It's the recurrent challenge with any additional workforce that comes into play. It's a problem that we've seen across the board, both in terms of normal workforce within general practice and especially with the PCN workforce, because it's seen as a slightly different view. And it's a problem that very few places, I think, have come up with really genuine answers. I think we've tried to suggest some different opportunities that you can look at. I know I'm a big fan of, reconverting existing administrative space into clinical space with the use of, secluded containers, things like the room, that kind of stuff and things. I think they're real opportunities for people to consider, and obviously remote working, we're massive proponents of it in some ways, how it can work effectively, but it is not the fix for everything. And I think the recognition of the fact there's no estates support in a lot of this stuff is a testimony to, again, how some of this has not been thought through fully and can definitely be enhanced upon. And it'll be really interesting to see how that changes with ICB movements forward, because actually this is going to be a growing problem. My network is anticipated to have 35 plus whole-time equivalents. That's more than 35 people, because some of them are part-time working. So how are you going to fit all those people in? And actually then does that mean that you don't have other workforce working general practice, which is why people then say they can't see somebody? Hello.
Yeah. So, but one positive thing I'll extend on, just this is something that I've seen done across Nottingham, where a number of primary care networks are working together. Sometimes what you need is a structure, say within a team like the pharmacy team, that allows then more experienced pharmacists to supervise and support and debrief less experienced pharmacists, and to kind of coordinate the service. And actually you wouldn't necessarily be able to support somebody like that from a single primary care network, but actually if you have a group of primary care networks working together, sometimes you can pool some of the ARRS resources together and employ somebody across who works across a number of primary care networks to provide that sort of support or debrief or supervision structure. I don't know if I've articulated that quite right, Gandhi, but I think people can perhaps think about and play with that concept if they're not doing so already, and work with other primary care networks in their area, potentially to do things together using the ARRS funding.
Absolutely. It seems clear to me, but that cross network working, I think, is a real opportunity for some places, particularly if you're covering similar footprints or providers in terms of place-based working and stuff. Yeah.
So good. Okay, right. Well, we covered an awful lot there, Gandhi.
Yes.
That was
apologies all. It's slightly longer than anticipated, but as you can tell, there was so much content in there. So you may even need to go back and re-listen or re-watch some of this stuff.
Maybe we can put the bookmarks in.
Yeah, we'll try and get the timestamps and stuff into there for you as well. There is so much opportunity here, and we would love to hear from yourselves. What are you considering doing moving forward? I appreciate for this financial year, many people have probably already got their plans sorted and submitted, but maybe this has helped in some way. And if that's the case, definitely leave a comment down below. Alternatively, for your October submission, your plans for the next financial years, which of these ideas are you going to be potentially considering using? Which are you going to extrapolate from? And have you got others that we haven't covered? We would love to hear them.
I'm sure there are lots of ideas
to hear them and stuff in terms of what are the options that you can consider using across the different roles and innovations and that kind of stuff. We would love to hear more of this and stuff. So absolutely, if you want to stick that in, let us know. I've just closed my computer, which makes it a little bit more tricky to do some of this stuff now.
Okay, well, I can certainly hit the end broadcast button if I just make my way over to the corner. And Gandhi, do you want to sign us off?
As ever, if you've got any comments or questions, let us know. We would love to hear all of this stuff from you, and we are always here to help take and answer your primary care and learning. We'll catch you all in the next episode. See you later.